Now to present you some reflection about cardiac arrest center and also the experience that we have in Paris. Something maybe you don't know, but I've been working on sudden cardiac death for more than 25 years, and I realized early and more than 10 years ago that many doctors, many people, many nurses, many paramedics were involved in the fight against sudden cardiac death. On the top you have electrophysiologists. The electrophysiologists, they are sure that they are the only one to work on sudden cardiac death and that they are the most important. Then you have cardiologists. Cardiologists, they are sure that they are the most important to work on sudden cardiac death and that they are the only one. For intensivists, that's the same. They know that they are the only one and the most important to fight against cardiac death. And then you also have all the physicians and nurses on the field, which are sure that they are the most important because they are the first step. And the thing is that every part of this pyramid work separately from others. They have their own congress. In cardiology, we have congress. For intensivists, there are special congress. For emergency medical service, or special congress. Also special reviews. We read the reviews that are concerned by our field. We have a European Heart Journal and circulation in cardiology, you have resuscitation, you have different things. So every step of the pyramid was working separately. And we want, and also one failure of this approach is that if you take into account only the variables belonging to your step, then maybe you can reach wrong conclusion. I give you one example, which is the therapeutic hypothermia. Therapeutic hypothermia, if you look at the variables only in intensive care unit, then you conclude that therapeutic hypothermia is very efficient and associated with a better survival. If you take into account variables from the other steps, then it's not so evident. So that's the reason why we decided to build a center in Paris dedicated for a sudden cardiac death. We needed 2 years to make it possible for everyone to work together, which is one big issue with the ego of the people and with the fact that people, they have to share something together, expertise, experience, and data. And to share also responsibility, which is not so easy. And so as you can see, we take some every case, and I will show you later, every case of sudden cardiac death that occur in Paris and suburbs with firefighters, with mobile emergency unit, those who reach hospital alive. And we do also medical follow-up, prevention, we do family screening, we do expertise, we do teaching and research. I will show you later. So now we open in 2010 and we open our registry in 2011, and we have right now more than 28,000 of cardiac arrest cases. So why it is important to build a cardiac center and why it is even more important right now? We know that cardiac arrest is a real burden. Cardiac arrest represents between 5 and 10% of the overall mortality. And the survival rate is very low. But now, with all the CPR teaching in schools and in many different regions, then we observe an increasing number of patients reaching hospital alive. Also, new techniques are now on assessment, and ECPR was discussed just the presentation before, but also we have other techniques. And now we realize that is it time to build multidisciplinary team, and those cardiac arrest center has to exist since they are not really existing right now. What are the different roles for a cardiac arrest center? The first one is to improve care. We have to provide the maximum level of care to improve survival. When we talk about care, then we have to talk about prevention of cardiac arrest. We have to talk about coordination of physicians and nurses on the scene, on the mobile emergency unit. We have to talk about management, what is the best medical management, and also about prognostication, and it was one previous presentation, neurological prognostication, but not only neurologic, and also rehabilitation. What is really the interdisciplinary team, and composed of who? The emergency mobile medics and paramedics, for sure. They are on the field and they are dispatched at home, in public place, on the streets, in sport also. Then we have intensivists. Intensivists, they work in resuscitation room, in intensive care unit, and they have now very efficient tools. We discussed already about the potential role of the therapeutic hypothermia, and now, and that was the presentation, we have extracorporeal life support, ECLS, which is proposed for refractory cardiac arrest, so no ROSC. And now we discuss about the ECPR, extracorporeal cardiopulmonary resuscitation, in hospital, but also out of hospital. If we send, and it was shown, if we send a mobile unit just installing the ECPR at home or in public places, it's time consuming, it's human resource consuming, it's very money consuming also. But if we have a good results, maybe it's worth. But we don't have the answer right now. But also, in addition, we have now the possibility to install a percutaneous mechanical circulatory assistance, and also we have to manage the post-cardiac arrest syndrome. So that's a big job for intensivists, but also new tools to assess. The cardiologists, they have to perform the coronarography and PCI, and I discussed it before. The electrophysiologists, sometimes they have to do ventricular stimulation or ablation of ventricular tachycardia, and also to discuss an implantable cardiac defibrillator. The radiologist, we need absolutely imaging of the brain, imaging of the heart, imaging of the thorax also. We need neurologists for prognostication. We need also psychiatrists, because as you have seen, even when the patient is very successful, is surviving, then most of the case, he has depression, mental depression. So we have to help him. But also, we have to help the family. Because for the family, when you have a cardiac arrest, usually the patient is not surviving. It's like a storm. There was no patient, he was not ill. He died without having been ill. It's mentally destroying themselves. So we have to help the family, especially when the patient is young and not surviving. And also we need the help of a genetician, because sometimes we have to do a family screening and genetic screening in the patient or within the family. So there are many questions. How many hubs, like I described, do we need? I don't have the answer. Do we need to divide those centers in primary centers, in secondary centers, in tertiary centers? How many of them? How to make it possible for them to work together in a network? I don't know. Which service we have to propose to be open 7 days, over 7 days, 24 hours? It's very expensive to maintain all this open every time. What human resource we choose to invest in those new services? That means that maybe we have many money, or maybe we have to remove human resource from other destination to put it specifically on sudden cardiac death center. It's a choice. I don't have the answer right now. And also those centers, they have to do research and teaching. And I will show you some data that we collected during these 8 years of cardiac center in Paris. First of all, we are collecting every case of cardiac arrest which occur in Paris and suburbs, which is now a population of 7 million right now. So 10% of the French population. Every case of people who drop dead, then we have the first step is a firefighter. They go on the scene, and then we have a mobile emergency unit. We collect every information by the firefighters. There are not so many, it's a short information, but very important for the denominator. Then, for every case, we collect the information by the mobile medical emergency unit, le SAMU. If there are discrepancies between firefighters and mobile emergency unit, every month we go to each place to correct, to have a very good quality database. Then, if the patient is surviving, is admitted to the hospital, and we collect systematically the medical information from the intensive care unit. And if he's still surviving, we collect information in the cardiology ward. So we have right now a big population, and that helps us to address several issues. And I will show you several. So, first point, where do cardiac arrest occur? So we put it here. You have Paris, and you see very rapidly that you have many cases among stations. So we decided to cut Paris in small boxes of 200 meters square and to look for the characteristics inside each box in terms of gender, age, socioeconomic status, pollution, inhabitants, number of inhabitants. And we expected the number of inhabitants to be the variables associated with the highest number of cardiac death. It's not the case. The variable, the most important variable associated with the cardiac arrest is the number of people crossing this box. It's the movement of population across those boxes, which is the most variable associated with the sudden cardiac death. So then we decided, okay, we will look at those boxes where you have the highest number of sudden cardiac death. So we have chosen different places. We have chosen stations. And in the stations, we have chosen also a touristic place with roughly the same number of people visiting or crossing those boxes. So for same number of patients, of subjects. However, you see that the number of cardiac arrests which occur in stations is 4 or 5-fold higher than number of cardiac arrests in touristic place, which is probably related to mental stress. People in train station, they are afraid to be late for their train. Also associated with physical stress, they run with their suitcase, they are late. Both associated. But that's an important approach, trying to help politics where to implant defibrillators. Another question is, okay, is there an optimal number for automatic external defibrillator for a given city? For example, in Pavia, you have location of automatic external defibrillator. What is the optimal number? How to address this issue? So in Paris, what we have done? We have used a matrix calculation. The RISCA algorithm is that what is used in your cell phone in order to assess the distance when you want to walk or to use your car. It's the same. And we add the geolocalization of all cardiac arrest. So then we assess, according to different hypotheses, the distance between automatic external defibrillator and the location of the occurrence of cardiac arrest. And we had different hypotheses. If we put here, you have a density of distance. Sorry. A density of distance. If you, for example, if we implant automatic external defibrillator in district council, we have 20 district council, so it's dark green. That means that the distance is very important between cardiac arrest and the location of automatic defibrillator. So it's not efficient. If you have to run 500 meters to catch it and 500 meters to come back, then it's too long. Okay, now second hypothesis, if we put it, the automatic external defibrillator, in the post office. We have 200 post office, so in certain place of Paris it's good, but in other place it's still a too big distance. If we implant it in subway station, then the distance decreases. We have 300 subway stations, it's better. And then we have pharmacy. Pharmacy, everyone says, yes, pharmacy is the best place to put automatic external defibrillator, because everyone knows the location of pharmacies. You have a green cross, so it's very easy. It seems to be very logical to install automatic external defibrillator in pharmacies. So look at what we observed. Pharmacies, 1,500 pharmacies in Paris. And it's quite good. But look at this. If we put it in Vélib, a bicycle station, then we have less than 1,000, so 500 less compared to pharmacies, but a better pattern. Why? It's because sometimes in a given street you have 3 pharmacies and you have no pharmacies in a residential area just beside this street. But, for example, the cities has been really thinking about the optimal location of Vélib station, bicycle station. So sometimes what seems to be very logical is not exactly the best solution. Another point is that, okay, we look at for the location, and now what is the best number of external defibrillator? Are we able to address the numbers? For Pavia, is it, I don't know, 50, 100, 200? How to know this? You know, probably, that the international recommendation is that you have to put an automatic external defibrillator once you had 2 cases of cardiac arrest in 5 years. In the previous 5 years. And then we said, maybe it's not a very good one. Maybe we have to install 1 automatic external defibrillator if there was 1 cardiac arrest in the past 3 years. So that seems quite logical. So, okay, using the same mathematical approach, we have here in axis, you have in horizontal axis, you have the number of defibrillator, and here you have the median distance according to different hypotheses. If you have a very small number of automatic external defibrillator, then the distance will be too big. So it's not a solution. If you have only for Pavia, I don't know, 10 defibrillators, okay, it's not a solution. It will not help you. But you understand that maybe after, I don't know, 1,000 or 2,000 automatic external defibrillators that you have in Pavia, installing, I don't know, maybe 100 more or 200 more is doing nothing. Look at this. You have a curve. If the number of automatic external defibrillators is very low, then the distance is very high. But then after this curve, you see, you have a line, a plateau, we can tell. So then we have 100,000, so we have 1,000 or 2,000 or 3,000 defibrillators, but the distance is not decreasing anymore. So the optimal number is in the curve, probably in the curve. And this approach can be used for every city in order for us to do some lobbying with our politics to convince them to install the optimal number of automatic external defibrillators. Now, another point I would like to address with you is this question. Is it possible to identify subjects with acute sudden cardiac arrest before their cardiac arrest, but only minutes before their cardiac arrest? You will tell me, yeah, it's a joke. Maybe it's a joke. Let's see this. Look, you know that more or less 3/4 of cardiac arrest are due to a coronary occlusion with, as a complication, a ventricular tachycardia or a ventricular fibrillation. Okay, that's the global pattern. The question is, okay, for given subjects, we have a myocardial infarction, a coronary occlusion, for example, a ST elevation. Okay, let's look only at the ST elevation patients. The same subjects, we have the same ST elevation, the same coronary occlusion, but then followed by a ventricular fibrillation. How to identify those two subjects with ST elevation? One without ventricular fibrillation, one with ventricular fibrillation. So we use in Paris and suburbs a registry of ST segment elevation patients, and we build a model. So this result was between 2006 and 2010. Now we have the double number of patients, and we had a derivation sample, we have a validation sample, we have an external validation. That's the appropriate approach when you want to build a score. And what we did? Okay, we had 8,000 STEMI patients, real STEMI, no discussion, real coronary occlusion. Most of them do not have ventricular fibrillation. Only 5% of them had ventricular fibrillation and sudden cardiac arrest. So we look at the characteristics of those with ventricular fibrillation in comparison with the characteristics of those one without ventricular fibrillation. And we were a little bit surprised. It was not exactly what we expected. Look, those with sudden cardiac arrest, they have less diabetes, less hypertension, less obesity, more shortness of breath, which is logical because it's more cardiac failure, and the delays were shorter. So we expected exactly the opposite. We can discuss why we observe such surprising observation. But then we build a score, and using this score, you see that for those who have a score above 30, they have 18-fold increased risk of making a ventricular fibrillation minutes after the ST elevation. This score is very easy, very basic. Age, no diabetes, no obesity, short delay, heart failure. Very basic score, easy obtainable on phone. And you see that we have a very good concordance of predicted and observed curves. So we published it, and so we wanted to observe it. It was possible to see the same in other populations. That's what we did in the United States, in Oregon. Oregon SUDS, Sumit Shug, is performing a very interesting study and database in Oregon. And we observed that 50% of patients with a cardiac arrest had symptoms before their cardiac arrest. The point is that it's not very specific symptoms. That's chest pain, that's dyspnea, syncope, palpitation. So that's not specific, but they have symptoms before the occurrence of cardiac arrest. And 93% of them during preceding hour. So, beside long-term prevention, beside resuscitation, there is a room for, I don't know what name, near-term prevention, preemptive action, acute prevention, I don't know what exactly is, but it's related with those minutes before the occurrence of sudden cardiac death. And everyone says, yes, what are the most the minutes which elapse after the occurrence of sudden cardiac death are the most important. Everyone knows this. Now, I don't share this opinion. The most important minutes are those before the occurrence of sudden cardiac death. Why? Because during those minutes, then we can ask for bystander assistance. We can just ask the neighbor, okay, do you know how to do a cardiac massage? By phone, we can dispatch advice. Okay, I will teach you how to do a cardiac massage because, you know, according to the very easy variables in the score, maybe you will do a ventricular fibrillation in the minutes following. We can also identify the closest location for the automatic external defibrillation and ask a neighbor to run for it. We can send immediately an EMS, emergency mobile unit, towards the home of the patient, and we can deliver instructions. So that's a very interesting direction. And also, beside, you know, all those circles of resuscitation, now there is a new circle in this chain of resuscitation just before the occurrence of sudden cardiac death, which we can call anticipation or something like this. So that's a new direction, and we are very excited about this new direction. And the last point I would like to address with you is a particular point, a little bit provocative. What do we do with non-survivors? I have to tell you, I have been working for more than 25 years on sudden cardiac death, and I began to work on non-survivors only a few years ago. Because in 90% of cases, the patients that do not survive, the overall number of population, not those with VT, all of those with cardiac arrest. And you know that there is a shortage of kidneys, there is a shortage of organ because we don't have enough organ for patients in end-stage cardiac failure, end-stage renal failure. And those subjects, they are dying because they are waiting for organs, but we don't have enough organs. So I said, why not using those non-survivors and proposing some of them for organ donation? The point is that we don't have to fail when we do this choice. Because the worst would be to propose a patient for organ donation and maybe this patient could have survived. It's not possible to do this mistake. So we have to work exactly at the opposite. We have to try to build model in order to identify subjects without any chance of survival, 0.0. And you know that there are termination rules which are existing. Termination rules that, okay, that's in Canada, they have observe these rules, and which is, okay, how to identify subjects with no chance of survival, and we can stop the resuscitation maneuvers. Our approach we called is orientation rule, because we will orientate the patient towards another direction, are different from termination rules for 3 reasons. The first one, our orientation rules concern patients with absolutely no chance of survival, 0.0. Second, these patients should be eligible for organ donation. And the third one, we don't stop resuscitation maneuver. We continue resuscitation maneuver. We know that we will not save the patient's life, but we'll save the organs. So we identified very easily 3 variables: non-EMS witnessed cardiac arrest, and initial non-shockable rhythm, and no ROSC after 3 times of 1 milligrams of epinephrine injection. Then we look for eligibility for organ donation, and if it is yes, we propose these patients for an organ donation, but we continue the maneuver, the cardiac massage. And we have identified prospectively, according to those 3 criteria, almost 800 patients who died, 0% survival. And you know, you have to be sure when you propose a score like this. It's so important that we wanted to have other assessment of this score, and so we used a validation score in our own Paris center, 3 years of prospecting data. We use also a case control study, and we also worked in Seattle, and because, as you know, Seattle is the mecca of sudden death, and we use their data, and okay, we check that according to those 3 criteria, you have 0 survival. So thank you for your attention. That's still my research team.